Yeah, maybe I can start now. My name is Hoyn, the editor of Global Psychiatry Archives, and I'm just trying to start this chat again. And we have the pleasure to see Professor David Ndetei. I don't know how to pronounce it correctly, Ndetei, or how do you?
Well, Ndetei, that's fine. You have done very well.
All right, okay, try my best, we work together, and he's the editor, one of the editors of Global Psychiatry Archives. Professor Ndetei has a very long experience in one place, which I admire. I think you have been director in the Psychiatric Institute in Kenya, or Nairobi, Kenya, for quite some time. I think you worked with Alzheimer's. You have a very broad experience. You have, I think, worked with voluntary organizations. You founded voluntary organizations, and I'm really impressed by your experience. I think you were all over the world giving your experience, and I'm very, very grateful for your contribution today. And especially because I think this is something very important, what we want to do with the Global Psychiatric Association, not being very national, but using the experience from different countries to allow other countries to learn. And usually what I'm very interested very often is, I'd love to know what is more or less what is happening in the world and what can we learn from other countries. So, and especially when we here sitting in Britain and mourning about poor resources, but you might know about that. So I hope I haven't waffled too long. I'm very grateful for your contribution, and certainly you will get the presentation, and certainly you're the ones as well. Okay, can I ask you for your presentation now, and let me know when you want to go for the next slide.
Okay, thank you very much for that beautiful introduction. My talk go back to the previous slide.
Second. Okay, just no, just give me a second. It should work.
Oh, okay.
Right. That's the first slide.
That is a second one. We start with the one that you are showing when you are introducing me.
Okay. Is it this one?
No. No, should be the second one. But anyway, never mind. I can start from here. Once again, thank you for the introduction. I work for, or I'm associated with the different organizations. First, the University of Nairobi, and then the African Mental Health Research and Training Foundation, which also holds the World Psychiatric Association Center for Research and Collaboration. Yeah, that one, for research and training. So today I want to talk to you about towards reduction of treatment gap in mental health in low and middle income countries using already available resources. And I'll share you with the Kenyan experience. And when we talk about the resources that we have, compared with what resources are available in UK, for example, where I trained, you realize that our resources are almost nothing compared with what the Western countries have. But we believe we can do quite a lot with the resources that we already have. Next slide. Yes, I think I've already said that, so we can go to the next one. Now, the mental health treatment gap. the mental health treatment gap is defined as the difference. Can you put the slides more to the left so that more to the left?
Okay, give me a second.
Sure.
Okay, slideshow. Also to the left.
Yes.
But no, I'm really struggling at the moment, but you know.
My problem is that part of my written presentation is covered by your portrait and my portrait.
Right, okay. So we take it.
Yes.
Is that better?
Yeah. No. Why don't you just remove our portraits and then we can come back when necessary.
Okay.
Yeah.
Okay. Is that better?
No. Is it possible to remove my portrait and your portrait completely out of the screen if it's not possible to push it to the left, towards the left?
To be honest, I don't see it here, but I can start again here.
Yes.
Start again. I'm struggling here at the moment. Doesn't start. If not, we have to start from square one. That's very sorry for that. And I have to do it again. So sorry for that.
And that's okay.
Try again. Mm-hmm. Mm-hmm. So the whole of this stuff is gone now, so I have to find it. Don't worry. Stuff in here. No, it's not. Okay. One of the things I can't get away with the with the outer side here, so that's my problem.
Oh, okay. I think I have a solution. Oh no, but you'll not be able to see it. I can present from my hard copies, but the viewers, the rest will not see. Will miss out information. What I'm asking,
Can you not see this? What the only other thing I can see, I can just give me a.
Yes, I can see it, but the problem is my photo and your photo and a few other things cover the
Then
right
take your
hand
video
of
off,
light.
you know, so that's no problem. If you take your video off, it should work.
Right. Can I do that and see what happens?
Yeah, you can take your video off and you can move. You can also move. Can you see it? Is it better now?
No. Yes, let me. Yeah. Yes, that is okay for me.
Okay.
Okay, fine. Thank you very much.
Sorry for that.
So I hope the other viewers can see what the full range of what I'm reading. No, I'll start again by saying that the mental health treatment gap, which we all know, is defined as the difference between the number of people who have mental disorders and those who cannot access appropriate treatment. And it is estimated to be as high as 85 in low and middle income countries, compared to only or an average of 40 in the high income countries. This high treatment gap in low and middle-income countries is unacceptable and represents an urgent global health priority. The good news is that the good news is that possible solutions to reduce this gap do exist within many LMICs. Next slide. We often blame this high treatment gap on resource scarcity. The resource scarcity includes human resources scarcity, shortage of specialized personnel, financial scarcity, income shortage at individual, family, and national levels, and the structural scarcity concerning infrastructure, health system, and the policies. These are the scarcities that are often blamed. Let's move to the next slide. The above resource scarcity are more apparent than real. From our experience, we believe that this resource scarcity mindset is a fallacy. This may sound controversial, but that's, I think, we see it. It could be just a fallacy. It is time to move away from this mindset if we are to eliminate the mental health treatment gap in LMICs, which I said it is unacceptable even today. Next slide. It is true that when compared to high-income countries, low and middle-income countries have a scarcity of mental health experts. That one we don't dispute. But such an is based on the idea that the high-income country model, where care is provided by expert caregivers, such as psychiatrists and psychologists, is a gold standard approach that LMICs must first attain to reduce the treatment gap. This Western high-income model, however, does not often translate into accessible and effective care in low and middle-income countries. Next slide. The questions that low and middle-income countries should ask themselves include the following. Rather than focusing mostly on expert caregivers, low and middle-income countries should find answers to two important questions. Number one, is the Western model where care is provided by expert caregivers realistic for low and middle-income countries in the foreseeable future? In other words, if we were to sit and say, we don't have enough resources, we don't have enough psychiatrists, and we don't have enough psychologists, and so on. So we have to sit and wait until we have trained of our own, and then we can start. So that is the answer to that question is that no, we cannot wait until we have enough of those. The next question is, what kind of human resources do we have in our own hands now? And the answer is plenty, many, a lot. Can we innovatively use these resources alongside the rather more expensive and relative unavailable specialists? The answer is a big yes. Next question. There's a huge pool of utilizable human resources in Kenya, and I believe in many African countries that I've been to, and maybe other low and medium countries elsewhere outside Africa. The poor can be, this book can be trained to recognize symptoms of mental disorders, offer first aid psychosocial support, and refer upwards and accept referrals downwards for continued support. Next slide. These include the families. They are traditionally the primary caregivers. Very important. We can't do without them. And excluding them will will result in very many problems in terms of providing services to individuals. We have a group of people we call individuals or people with lived experiences. They can be supportive of people with mental disorders. The clergy and traditional healers, this can be controversial, but there is a lot of literature, some of it based on randomized clinical trials. The clergy and the traditional healers can be effective in providing services and can be very effective in supporting the few doctors that are there to extend services to the grassroots level. There is an oversupply of these people, the clergy and the traditional healers, very many, all over. We can never utilize all of them if we were to utilize all of them at the same time. They are often the first contacts for care, even when specialists are available. And again, there is a lot of literature to that effect, that patients will go to the clergy, the traditional healers, and bypass a psychiatrist or a clinical psychologist on the way, because they want to be seen by their clergy and their traditional healers. Next slide. Community health volunteers. These, as far as Kenya is concerned, they are the backbone of community health services in all health-related matters at the grassroots level. COVID-19, HIV/AIDS, tuberculosis, nutrition, name it. Things that are fundamental to good health at the community level. Why not include mental health? They are the link between families, communities, and other community facilities. There is no shortage of them. And let me add here that now there is a new policy where the government will hire these people, and call them community health promoters, so that by law or by requirement, there will be at least one or two for a given number of people, so that they can achieve coverage. They are supposed to visit those homes, visit the villages, the homesteads, the families, and understand their health issues along the whole spectrum of health issues. Why not mental health be included as one of those? Next one. Next slide. School teachers and counselors, they are available in every school. They have an advantage of spending more time with the children than the parents. The class teachers interact with and observe the students more closely. They are required to make personalized reports on each student in their class. They are important partners. They are important part of the system in health care, in mental health care, do we utilize them maximally? Or we just want to talk about psychiatrists and psychologists and doctors and overlook them? Next slide. Peer counselors can be identified for schools, colleges, and universities, and for sure here in Kenya. And by the way, when I'm giving you these statistics or these statements, they are based on data that we ourselves have collected in Kenya. We have found peer counselors in school to be very effective in identifying and supporting students, fellow students, with anxiety, and using randomized clinical trials. It has been shown that those trained peer counselors are very, very effective. In fact, more effective than the teachers. And again, they are trusted by their colleagues. So they are very important. We need to ask them or involve them. But of course, as we involve these people, it does not mean that we exclude others. Doctors are very important, clinical psychologists are very important, so that if there is any need for upward referral, we can have a pathway to that. Remember, I said that we can use these other people for referrals upwards and also referrals and downwards from those highly specialized people to these other people at the grassroots level, so that they can support them, they can encourage them to continue taking any medication that has been prescribed. They can talk to them about, make them understand their condition and continue to take treatment. They can talk to them about stigma and so on. Next slide. Now we have clinical services, nurses, clinical officers, and the physicians working at community facilities. In those communities, you have community opinion leaders and the policymakers. They are very important in those communities, particularly the community opinion leaders. Whatever they say, it goes. It doesn't matter what other people say, but if they say as communities, the one where they are regarded as having the final say or a very important say, whatever they say, it tends to be respected. And of course, we need to work with policymakers. They provide conducive environment for mental health from grassroots level upwards. Can these different countries provide services? The answer is a very emphatic yes. Why do I say this? Yes, because we have the evidence, as I've just said. We have found that these different human resources can be expertly engaged to provide evidence-based intervention using the World Health Organization mental health treatment gap that is recommended by the WHO for use in low and middle income countries. As I've just said, we have shown that peer counselors as young as 18 to 22 years can provide evidence-based intervention. So in conclusion, low and middle income countries are not human resource poor. We may have different types of human resources, but they are there. Rather, they have abundant resources which can be co-opted into delivery of mental health services. And I want to say thank you very much for your attention.
Right, okay. Is this, have you finished?
Yes, it's finished.
Okay, thanks a lot. Okay, just have to give me some